So my name is Christine Torjussen from FHI 360. I am happy to be hosting this webinar today for the PrEP Learning Network, which is a virtual learning network that is supported by the Options Consortium, along with the EPIC and RISE projects funded by USAID. And we can go to the next slide, please. So this is an overview of our program for today. We're going to get an overview from our Jenny Albertini, our colleague in PEPFAR, on PEPFAR guidance on PrEP in the time of COVID, and then we're going to hear 3 examples from different countries of how they are delivering PrEP in this context. Continue. So I'd like to introduce our speakers for today. Our first speaker will be Jenny Albertini from PEPFAR. She's a senior technical advisor for HIV prevention and maternal health in the Office of the U.S. Global AIDS Coordinator in Health Diplomacy. She's worked on PEPFAR programming since its inception in 2003 through the CDC, USAID, and the State Department, while being based both in Africa and in the United States. We have Vusile Butler from WITS RHI in South Africa. She is a senior program manager, and she's responsible for implementing her portfolio of technical assistance and implementation programs focused on improving HIV prevention, care, and treatment outcomes for adolescent girls and young women, gender-based violence prevention, and strengthening child sexual assault prevention. Next, we have Tafadzwa Chakari from Jipaigo in Lesotho. Chakari is a public health practitioner with 15 years of experience in HIV prevention and treatment in Southern Africa, and he's currently the technical director for Jipaigo in Lesotho and is implementing both BMMC and community-based PrEP. We also want to welcome Wame Dakobe from FHI 360 in Botswana. She is the project director of EPIC in Botswana, which focuses on providing HIV prevention, care, and treatment services, including PrEP to key populations such as men who have sex with men, people who inject drugs, sex workers, and transgender people. So we're very grateful to have all these fantastic speakers with us today. Next slide, please. So as I've mentioned before, we unfortunately do not have a voice option for the attendees, but we can use the chat feature, and I'm very pleased with everyone who's been using it so far. In the chat, there is a little button that says who you are sending it to, and you need to change it. The automatic setting is to send your chat to all panelists. You need to actually manually change it to send it to all panelists and attendees so that everyone can see your name and also any questions or discussion that we have. Excuse me. So I just want to note before we start that at the moment we have 191 participants. It's quite an active group with participation from all over the world, and particularly a representation from Sub-Saharan Africa, and we're just so glad to have you all join us today. We're going to start with Jenny's talk and then pause after that for a question discussion period, and then move into our 3 country presentations. So with that, I'll turn over to you, Jenny.
Thank you so much. Can I just check that you can hear me all right, please?
Yes.
Okay, wonderful. Thank you. So good morning and good afternoon to everyone on the line. Thank you so much for joining us for this presentation today. I know I'm especially interested to learn more from our country colleagues on how they're doing the work of scaling up PrEP and monitoring program implementation during this challenging time. If you could go to the next slide, please. So as Kristen mentioned, I'm speaking on behalf of the PEPFAR program, working in collaboration with our colleagues at CDC and USAID in support of PrEP scale up around the world. I hope that everyone trusts that PrEP has been shown to be a critical intervention in the PEPFAR prevention cascade that we support. And of course, as many of us are all dealing with that, as the COVID-19 pandemic has evolved, even just over the last 6 weeks, we've seen a variety of infection prevention measures being rolled out in countries around the world. Each country is, of course, deciding what works best for them based on their particular curve of the epidemic. But we have definitely noted that PrEP and HIV/AIDS programs have been dramatically affected so far. So within the allowable public health boundaries of the emergency response, PEPFAR is, of course, part of a larger US government response. Many people have probably seen our leader, Dr. Birx, the Global AIDS Coordinator, in her other job now, working at the White House as the Coronavirus Coordinator. In addition to that, she's, of course, feeding into what we're able to do with PEPFAR programming and the resources and support to our country teams. So at the end of March, we, as a PEPFAR program, started issuing twice weekly frequently asked questions through our pepfar.gov website. These are being updated in real time as closely as possible to provide support to countries and teams as to how PEPFAR funded activities should be operating during this time. Based on some initial questions we received from colleagues in the field about how PrEP should continue to be operationalized, on April 8th, we were able to contribute a series of PrEP-specific recommendations were issued. These take into concerns issues around multi-month dispensing, monitoring and evaluation, demand creation, and virtual support. I'm going to touch on these in my presentation today, and also they're all publicly available in the full context online, and I think they're being shared as part of the resource from this presentation. So it is helpful to note that we look forward to continually hearing from colleagues, such as on this panel today, about real issues that we should be addressing within these FAQs so that we as an interagency group can continue to have them evolve and be most helpful going forward. Next slide, please. So PEPFAR and PrEP have been, PrEP has been a major part of PEPFAR's prevention program for the last several years. As of the end of the last fiscal year, we were supporting over 160,000 people around the world. In the way that we're able to dedicate attention to this within the PEPFAR country operational plan guidance and through senior leadership around the year is that we have an interagency community of practice on PrEP implementation that brings together the experts in all of the agencies working on PrEP. And I'm pleased that several of my colleagues from CDC and USAID are on the line today and will be able to help address questions. But the goal is really to make sure that country teams are receiving adequate technical support to carry out PrEP activities, and that we can weave this as an intervention into key activities that go on, such as through the DREAMS initiative, key populations funding and practices, and that we can also highlight the need to scale up PrEP in specific populations, such as pregnant breastfeeding women and discordant couples. Next slide. So as many of people are feeling on a real-time basis, we have both the primary impact of COVID-19 and the pandemic right now. This is, of course, the illness that patients are experiencing and the healthcare worker strain, the burden on our healthcare system, and significant disruptions to the supply chain system. But we are also concerned about some of the secondary impact that is happening because of these physically confinement measures that are critical to stopping the spread of COVID-19. We are concerned of the growing potential for increasing rates of sexual exposure to many people and the fewer interactions that will be available for people to learn about PrEP or other prevention tools during the quarantine periods. Next slide. So some of the PEPFAR resources and support that we've mentioned are that we have on our website specific guidance related to coronavirus that's being updated twice a week. We're also working very closely with all of USAID's supply chain systems to make sure that emergency orders and planning have commenced. We've been able to push back monitoring and evaluation reporting deadlines for our partners. So those are now being due at the beginning of June. And we have some recommendations in place to look at what is considered an essential service at this time versus services that can be delayed or limited. So for instance, cervical cancer and VMMC services are paused or are in limited availability right now, depending on the context. And that we are spending a lot of time making sure that our teams, some of whom have had to evacuate countries, some of whom are on telework, some of whom are not able to get out to sites, are being supported as best as possible. Next slide. We do want to make sure that if you take nothing else away from this morning's presentation is that you know that HIV prevention activities, including PrEP, are considered essential services within the PEPFAR platforms right now. And that what we hope is that they can be adjusted as best as fits possible for any country's specific guidelines on social distancing right now. We do have staff who continue to work, and we are supporting multi-month dispensing of PrEP. We hope that these will alleviate some of the congestion that healthcare systems are facing right now while still maintaining support for clients. Next slide. Some of the specific activities that we're recommending be paused or reimagined include demand creation activities. So in many places around the world, large social gatherings, people and groups above 10 have been prohibited. And so we support that. So we're looking forward to alternative methods of getting connecting with people, whether it's through social media platforms, webinars, WhatsApp, Facebook, Instagram, and to encourage community cohesion in other ways. So we know that there's many options for how people can continue to ask questions of their healthcare providers and their colleagues and their peers, and we're looking forward to hearing later about some of those examples. Next slide. As I mentioned before, we've pushed back some of our monitoring and evaluation deadlines, and we do want to recognize, I think for everyone, that this is what we know and believe to be supportive as of now. I think as each week goes by and we learn more about how COVID-19 is spreading around the world and its impact on health systems and also implementation of programs, we're going to try and adapt and be nimble with responses from our office as well. Next slide. Within the frequently asked questions document, you'll see our key populations working group was also able to put forward some specific programming in relation to work during COVID-19. And so, we support this also, that refill of PrEP, and it can be carried on through community initiation. We see this as a major component of prevention activities for this group. Next slide. Okay, next steps. I know that we're going to have plenty of time for question today, and I will say that what's really most important to us at PEPFAR and within our interagency community of practice is that we hear from colleagues who are managing programs in country, and to understand what are the nuances of difficulties you're facing and what new strategies you're trying to support to make sure that clients are able to continue initiating and adhering to PrEP throughout these next several months. We look forward to hearing about this and learning how we can adapt and adjust our PEPFAR PrEP guidance within this context over time. And then, because earlier this year, a lot of us spent time during the country operational plan process talking about how there were grand plans for scaling up PrEP over the next year. We really want to try and anticipate that future, the time when we will be able to carry on our activities in perhaps newer ways, but still with an eye towards bringing the most effective and critical interventions to clients and patients around the world. So we'll figure out how to move forward on those goals once we get there, but just so everyone is aware that we're also going to be looking forward to the chance to do that after social distancing restrictions are relaxed. So next slide. Thank you.
Wonderful, thank you. If anyone has any questions for Jenny, please go ahead and type them into the chat to all panelists and attendees, and then we will come back to them. I think for the moment, we will actually move on to our country presentations. Okay, so I'm happy to turn this over to Vasile to tell us how they are delivering PrEP through their Project PrEP program in South Africa. Over to you, Vasile.
Thank you. Hello, everyone. My name is Vasile Butler. I'm a Senior Program Manager at WITS-RHI. I'll be doing a short presentation to you about PrEP and SRH service delivery during the South African COVID-19 lockdown. This is the Project PrEP story. Next slide, please. So On this slide, I provide a brief snapshot of the project. Briefly, Project PrEP is a 3-year Unit 8 funded project providing PrEP as part of a comprehensive SRH package in 8 fixed facilities and 4 mobile clinics in 3 provinces in South Africa. I won't read the project objectives that I've just put up on the slide, and neither will I have time to go into the detail of program strategies. But what I do want to point out at this time is that at the end of March 2020, we had 7,234 total PrEP initiations, of which 3,804 of those were AGIW. The remainder were in other groups. We've been initiating since December 2018. Next slide, please. So again, I will not spend a lot of time on the slide. All it does is just shows a high-level timeline of the pandemic. Notably, South Africa's first reported case was on the 5th of March, and the country went into full nationwide lockdown on the 26th of March. We're still under that lockdown. The COVID stats were true as at the 14th of April. Next slide, please. So immediately when the national state of disaster was declared, the project swung into action in anticipation of a lockdown, as that was the path that many countries around the world were following to manage its spread. The project did 5 things in preparation. The first thing it did is we determined which project staff were essential and which were non-essential. We then strengthened communication systems at all levels. So for example, we ensured that staff had connectivity to work from home. We established protocols for regular and irregular reporting. We made sure that all staff were reachable for instant communication, as well as all active clients made sure that we're reachable in WhatsApp groups. Thirdly, we provided COVID training online to all our staff and simultaneously developed duty rotational shift rosters for ground staff. This training was developed by the National Institute of Communicable Diseases. The next thing we did is we strengthened infection control measures and started distributing National Department of Health developed COVID-19 related IEC materials. We rapidly procured PPE and distributed that to all of our facilities and the mobiles. So by the time the lockdown hit, we had a clear plan in place. Next slide, please. On the 27th of March, the National Department of Health issued guidelines on PrEP provision. These guidelines emphasized the following, I'm summarizing. 1 was the need to ensure continued access to HIV testing and PrEP, using adaptive strategies to simultaneously reduce patient exposure to COVID-19. Secondly, a multi-month dispensing methodology was to be adopted, 2 months, issuing of 2 months for clients that have been historically continuing on PrEP. Thirdly, a more intense remote follow-up of clients so as to reduce exposure and traveling where possible. And that also we make attempts to improve access for clients, drop-off points, and arrange to deliver to clients where possible. Next slide, please. So on this slide, I'm sharing, I beg your pardon, pivoting our strategies in light of COVID. We had to rapidly define our implementation strategies in the midst of COVID-19. I share some of our highlights of our pivot. Project PrEP has historically had a huge emphasis on demand creation. We had to respond to the call to maintain social distancing and to not have large gatherings. Therefore, social mobilization activities ceased in the community. And we pivoted to focus on small, even one-on-one discussions. Demand creation officers have assisted with sharing PrEP and COVID integrated messaging. On the ground, we even created a job aid for them to use. There was also online sharing of where mobiles or mobile clinics would be and when they would be there. Regarding initiations, our mobile clinics park on the grounds of clinics and serve to decant patients from the fixed facility by offering PrEP and SRH services to clients from the mobile. Multi-month dispensing has also been implemented. A learning in the early days of the response was that SRH can be easily forgotten, and thus integrated messaging is important. Follow-up is also critical, but more so now as lockdown presents so many constraints and challenges for PrEP clients. To strengthen follow-up, what we did is job descriptions of non-essential staff were adjusted to include client follow-up. WhatsApp calls and Zoom meetings take place on a regular basis to allow for dynamic interaction and team support. Next slide, please. We wanted to quickly share some initiation and continuation data with you on this and on the slide as at the 14th of April. Our data tells us people are still coming, and it's evident that PrEP is still in demand during lockdown. We've had a notable increase in initiations amongst AGYW with 334 initiations in February. Those rose to 480 in March. This we accredit to the intensive WhatsApp and online communication we did before the lockdown. We're still seeing a good number of continuations, but overall we see a decrease. This is primarily due to multi-month dispensing, one, and the fact that the data we've shown you is for half of the month of April. Additionally, people have traveled to other provinces where they call home for the lockdown. Some of the people locked out of the province where they ordinarily access PrEP have reached out to us either on the phone or WhatsApp or online, and we've connected them with the nearest PrEP initiating clinic wherever they are. Next slide, please. This slide just highlights our efforts through social media to ensure HIV prevention and SRH stays top of mind. Daily posts are scheduled and targeted boosts are utilized to ensure those in need of PrEP SRH services know exactly where to go and where the mobile clinic will be. We've used these platforms to push messages for integrated PrEP and COVID-19 messaging. This graph shows reach and engagement through Facebook during the first 4 weeks of the lockdown. What we call engagements are individual conversations through private messenger, those showing a balance between PrEP, HIV, and COVID-19 related topics. You'll notice that in the week that the lockdown was announced, the 23rd to the 29th of March, there was a lot more interest online, and it's increased since. Next slide, please. So this is my last slide, and in conclusion, I just want to cover some issues around key learnings and challenges. In terms of challenges, we've seen a strained supply chain for PPE and other commodities, particularly contraceptives. Transport under lockdown and travel permits are required for all essential staff, and there have been endless challenges on that front. There has been messaging ambiguity, especially around mask wearing, confusion between isolation and quarantine, etc. We also hear anecdotally that GBV rates have increased, and we're looking at this going forward. In terms of learnings, a rapid pivot is definitely possible, and we've been able to demonstrate program adaptability, and we've figured out a lot of stuff between the 5th of March and today to successfully carry on initiating PrEP, providing SRH services, and still supporting the South African COVID-19 response. The Department of Health guidance was very empowering, we found, and enabling, and made sure we lined up with the national response. We also see that communication is key, and social media is very useful, especially to get people to come in and when we need to pivot so rapidly, and a platform to clarify confusion around numerous issues. Next slide. Thank you so much.
Thank you, Vusile. That was great. I think we're going to move straight through the country presentations, and then we're going to come to questions. There's some interesting questions coming in on the chat. Next slide, please. Okay, we're going to move over to Chikari to talk to us about the experience in Lesotho.
Good afternoon, and thank you for the opportunity. So my name is Tafadzo Chakari. I'm the technical director for JAPEGO in Lesotho. And we provide community-based pre-exposure prophylaxis, trying to reach people who would otherwise struggle to get interventions from facilities, or those who prefer not to. So we work in three of the country's 10 districts, providing services that are mainly targeted adolescent girls and young women, female sex workers, and MSM. Can move to the next slide. Right, so I'm going to take you through a bit of background of our work in terms of community PrEP, and then go straight into the impact that we have observed of COVID-19 in terms of new initiations on PrEP, as well as people coming back for refills. Then my last slide will talk about challenges. So straight into the background, Lesotho is a small country with a population of 2.2 million. With an adult HIV prevalence of 25%, amongst the highest in the world, as well as an incidence amongst adults of 1.5% per annum. And as I mentioned before, JAPEGO is the partner that supports Ministry of Health with community-based pre-exposure prophylaxis services. Just to mention that Lesotho has not yet reported a single case of COVID-19. But that said, we are completely surrounded by South Africa, who I think currently have the largest COVID epidemic in Africa. So even though we have no cases, we are very alert to the possibilities of infections that might already be in our midst. And in response to this threat, Lesotho followed South Africa and other countries and instituted a nationwide lockdown on 29 March. And in this lockdown, most activities are ceased, including many health activities, except those that are deemed as essential, of which PrEP is one. Next slide. All right, so how have we responded to this? We continue to recognize that PrEP is an essential service, that sexual activity continues, maybe is even increasing, and that HIV transmission might be happening during this time of COVID-19 related lockdowns. But we have had to also adhere to concerns of transmission and stopped and put measures to comply with social distancing. So our teams, we have stopped doing face-to-face community-based demand creation activities. Like I said, we are the community partner, and our main strength is to get deep into communities, and we use many different models, but the one that worked most for us was using peers. So some of the PrEP users are engaged by the program, and they go around talking about PrEP and creating demand amongst their colleagues. So this is the first thing that we stopped, and we have continued sending out adverts on social media, like the picture that you see on this slide, basically telling, so these are circulated on WhatsApp and Facebook, telling people where our community resource centers are found and that we are open during this time of lockdown. We have had to stop our mobile community-based service provision, which is where most of our new PrEP clients come from. So, like I said, we try to go as deep into communities as possible, and because we are so accessible, that is where most of our new PrEP clients come from, rather than these fixed resource centers that we're trying to make more use of now. This will explain my next slides in terms of PrEP uptake. And maybe just go back to the previous slide, sorry. So we have also implemented early community refills. So when the lockdown was announced, our teams came up with lists of all of the people who were due for refill during the lockdown period, and they made efforts to contact them by phone, find out where they are, and provide them with a refill. Unfortunately, we have not been able to do multi-month dispensing for PrEP due to Ministry of Health policies at the moment, but we've found these people and given them a one-month refill, because we know that people were going to start traveling so that they are locked down in their home areas. So many of our PrEP users are students and factory workers. And then we're also doing early HIV testing for these people. So if they were due for an HIV test a week from now and they refill, we'll do the test immediately and give them an early refill. And like I mentioned, we're continuing with services only from the fixed resource centers. Next slide. So this slide shows how our initiations have been impacted. Like I said, our lockdown started on 29 March. So this slide shows how we were progressively increasing our PrEP initiations from 749 in November, and there was a progressive increase to March, where we had 1,687 new clients, and this was our highest ever monthly enrollment after 2.5 years of PrEP implementation. And then what did we observe? What have we observed so far in April? So that total for April, that 20 was the total midway through April, and I believe it hasn't changed too much, but you can see the steep decline from talking thousands to less than 50 clients. So we've only enrolled 20 new clients during the time of the lockdown. You can go on to the next slide. And then this slide shows how many people per month were coming back to us to either collect a refill or to restart PrEP. So we've always been around the 600s every month. And in April, thanks to our proactive approach of actively finding them and going to refill them, we were still nowhere near the around 600 to 700 clients, but we had managed to refill 265, and this total is for clients that were expected during the first 3 weeks of the month, which is where the initial lockdown was penciled for. And our teams are currently busy finding clients who need refills for what remains of April. Next slide. Right, so our challenges, this is the feedback we have had from our teams, is they work. So once our first reaction to lockdown restrictions was to recognize that it was our responsibility to make sure that those people on PrEP are given the opportunity to continue on it if they want to. And these are the challenges that we came across. The first one was that some clients were no longer available because, as I said, we work in 3 districts. And by the time we tried to find them, some of them had already traveled back to their home areas after their schools and workplaces had closed. And those that were available, some of them would tell our teams that, yes, I am around, but I cannot continue PrEP because, for instance, now I'm no longer in the hostel and I'm now living at home with my parents and I have not disclosed to them. And some were around, but because of movement restrictions, they were afraid of coming out and coming to wherever our services were because they were afraid of law enforcement. And then we also have some clients who told us that, no, I feel I'm no longer at risk because my situation has changed. I'm no longer at school, I'm now living with parents. So this said, we recognize that as much as some people might not be at risk because of their changed circumstances, there are some people who might have new risk, who were not at risk before lockdown. Lesotho has large numbers of people who work in neighboring South Africa. And when South Africa announced their lockdown a few days before Lesotho, we had many people returning home to be locked down in Lesotho. And our team takes this to mean possible elevations of risk. So we are now in the process of changing our mindset from not only supporting those who were already on PrEP before the lockdowns to finding those people who might feel that they are now at risk during this time. So we're trying to find, our way forward is we're trying to find the middle ground of getting our enrollments back up to speed whilst still maintaining social distancing and adhering to provisions as made by the government. I think this is my last slide. You can move to the next. Thank you. So this is one of the social media posts that our teams are regularly sending out, making sure that people are still aware of PrEP and so that they know where to find us when they need it. Thank you.
Wonderful. Thank you so much, Chakari. That's very interesting. We are getting lots of questions, but I think we're just going to move through our final presentation and then come back and go through the questions in order. So over to you, Wame.
Good afternoon, everyone. My name is Wami Digome from EPIC, Botswana. So EPIC in Botswana focuses mainly on key population programming. We provide services to female sex workers and men who have sex with men. We started providing PrEP for about a year and a half now, and we have about 840 MSM and FSWs currently on PrEP. We provide services in 5 districts, so the numbers are not that big, but it's been interesting to, respond to COVID and see how to adjust in providing services to our small but very important population. Next slide, please. So in terms of Botswana, I think we're similar to Lesotho. We're very close to South Africa, and our response to COVID overall has sort of modeled South Africa's response. We were one of the last few countries to be affected by COVID. The first reported case was in March. And during the month of March, there was a lot that was going on from the government's point of view, trying to implement the extreme social distancing policies and also making sure that infection control measures are in place. So some of the restrictions that we saw come right on before we even had a lockdown was the mandatory quarantine of travelers even coming in from South Africa, with only citizens and residents being allowed to return back home. We saw a ban of domestic and international travel, with only essential imported commodities being allowed in. There were also closing of schools and bars, and as you know, in a key population program, bars are very important. These are the hotspots where we usually go and reach our key population. There were also restrictions on gathering of more than 10 people. The first cases were reported on the 30th of March, and there were 3 imported cases at the time. And right after that announcement, Ministry of Health sent out a memo suspending labs, suspending all HIV-related labs. So viral load and CD4 count testing was suspended across all districts. And also the memo mentioned only providing MMG for 2 months for all PLHIVs, but it was really silent on MMG for PrEP. Less than a week after the first reported cases, we had the national national lockdown, which resulted in further restrictions of movement even within, localities. Can we go to the next slide, please? So prior to the COVID-19 pandemic, we were providing PrEP in a differentiated model of service delivery. PrEP was being provided at the static clinics, in our drop-in centers, and also during mobile outreach using our mobile clinics. Our providers were offering HIV testing to all KPs who were eligible to get tested. And once they have been tested, then they were referred to the nurse to be screened to determine whether they were eligible for PrEP. So this next level of screening really involves STI screening, assessing for risk perception, and also making sure that we draw the baseline labs at that time to check for renal failure and so forth. We used to provide at least 3 months supply of PrEP for all those that have been on PrEP for more than 3 months. So for the first 3 months, you were required to come in for a monthly visit to get HIV testing and also to get STI screening. And after being on PrEP for more than 3 months, then you were offered 3 months MMD for PrEP. And also adherence support was offered through, our drop-in centers where our peer navigators were able to physically interact with the clients and have support groups. Next slide, please. So post-COVID-19, demand creation activities moved mainly to virtual demand creation. We have an online platform where our peer outreach workers can mobilize and refer clients to access services through physical spaces. So this has greatly scaled up since COVID. because of the suspension of hotspots and physical interaction. At the facility level, all the infection control and social distancing measures are in place. We have started implementing an appointment system to limit the number of clients that access services on a daily basis. Clients are now required to acquire permits before coming to the facility, which has really been a cumbersome and tedious process. And to this date, we've been on lockdown for about a month, but there's still a lot of confusion even from the community on who can get a permit and how to go about getting that permit. So, you know, this has really moved us from providing services at the facility, even though we wanted to offer that service as a differentiated service, a model of service delivery. So we have since moved more to providing services in the community and providing more home-based services. We are in discussions with Ministry of Health to see how we can modify the current testing protocol. Our health providers are very concerned about the amount of time that is required to conduct testing, and we need to really look at how we can shorten that physical contact. We all know this from testing protocols that, you know, you have your post and your pre and post counseling services, and that can really take up to like 40 minutes in contact with a client. And it's one of the things that has come out from COVID, that our health providers are very nervous about spending that much time in physical contact with their clients. We have also stopped all baseline labs following the memo from Ministry of Health. Currently, we are dispensing 1 month for those that are newly initiated. And then after the 1 month, follow-up, then we can give that individual 2 months MMD. So this is really different from what we used to do pre-COVID, where for the first 3 months, you were given 1 month supply, and then only given 3 months after that first 3 months period. Home-based testing, like I mentioned, has become the new norm. Our providers go out into the community and provide these services within the homes of individuals who've been mobilized by our peer navigators, and ensure that they are still practicing the infection control measures. Next slide, please. So in terms of support for those that have started PrEP, those that were already on PrEP before COVID-19, we immediately before the lockdown, right when we started realizing what was going on in countries around us, especially South Africa, it was very obvious that Botswana would also have a lockdown pretty soon. So we started by listing and tracking all the clients that were due for refills and due for HIV testing through phone calls and home visits, and offered home-based testing, and offered also the 3 months MMD to ensure that they had sufficient supply of PrEP for during the times that will be on lockdown. We also had STI screening and TB screening and treatment referrals done at that time. Next slide, please. In terms of supporting those that are started on PrEP and those that are currently on PrEP, we have moved those services also virtually. Our beneficiaries are provided with phone numbers of our nurses and peer navigators so that they can call at any time and be able to access the services that they need, either the nurses coming to their homes or asking them to come to facilities if they're able to get the permits. We've also started online support through WhatsApp groups. You know, Botswana has a huge challenge in terms of internet connectivity and bandwidth. So most of the support groups that we currently have are through those WhatsApp groups and phone calls. There's also frequent check-ins by peer navigators for those that are newly started on PrEP. within that first month before we can give you the 2-month supply. And we're also implementing now a GBV screening tool, especially with the home visits, to just ensure that, you know, we're not putting our clients at risk as we go into their homes to provide these essential services, to make sure that we're not, you know, creating that other added risk of intimate partner violence. I think this is my last slide, but just from the other discussions in other countries that have shared in the region, the challenges that we're seeing come very similar to what is in Lesotho and South Africa. The challenges with PPE availability, challenges with the travel permits, especially when we're asking key populations to travel from their homes to go and access services in static clinics. That is a big challenge. And we, you know, as we go into people's homes, like I said, we still need to consider whether or not we're putting them at risk for gender-based violence as well. And because we have seen an increase in GBV cases just overall in the country, not just for the program. Yeah, that's my last slide. Thank you, everyone.
That's terrific. Thank you so much, Wame. That was wonderful. And I really thank all of our speakers and presenters. So we're going to go into a Q&A session now. And we have, in addition to our wonderful speakers, we have representatives in the panel from WHO, USAID, CDC, and the EPIC and RISE programs. I think I'm gonna start. I know there are a number of questions, and actually I do welcome people responding to the questions with their own experience in the chat. We are going to consolidate all of this into a resource sheet afterwards that we will distribute and make available. But I think we should start with a discussion around the multi-month dispensing of PrEP. It does vary by country in terms of what different countries are allowing, but I think this question is an important one for us to address of what do we do about multi-month dispensing of PrEP at the initiation visit, and how do we handle the importance of a HIV test after the first month of PrEP to avoid missing acute HIV infection. I turn this over to my panelists. Does anyone want to start with the response?
Christine, this is Shona Dalal from WHO. I can weigh in here and then let others add if they like. So just to say from the WHO perspective, we already suggest and recommend that experienced PrEP users should be given multi-month prescriptions according to the national guidance. In the context of COVID, I mean, usually we would suggest that individuals who initiate PrEP should return for the 1-month follow-up testing and the clinic visit before they receive multi-month prescriptions, mainly to exclude acute HIV infection and to assess intention to continue using PrEP, as well as to assess any potential adverse events. However, at this point, we understand the need for flexibility given the situation, and so we would say that for motivated clients who have not had a recent potential exposure to HIV, they could consider multi-month prescription for people initiating PrEP. But really the goal is to minimize the potential for providing PrEP to individuals with undiagnosed HIV. So we would suggest that the decisions are made on a case-by-case basis between the providers and clients who are initiating PrEP for the first time. Over.
Thanks, Shona. Do other panelists want to respond?
Yeah, hi, Christine. This is Chris Akolo from EPIC Project at FHI 360. So I think, like Shona mentioned, WHO has made some recommendations regarding multi-month dispensing for PrEP, and a lot of country programs, and mainly PEPFAR supported programs, are also looking at ways of making sure that individuals who are eligible for PrEP continue to access PrEP even under the current COVID situation. So what we're doing in a few of our countries, for people who are initiating for the first time, we're trying to follow the client-based approach or the client-centered approach, whereby you actually look at the risk of that particular individual, and that helps you to know whether this individual will actually require during the first month follow-up visit to have HIV test done, and whether that client will actually benefit from multi-month dispensing of PrEP right from initiation. Most places now, most countries now still follow that 1 month prescription for the first month of PrEP initiation. And then beyond that, they're considered for 2 months or 3 months, depending on the stock level at country level. But one thing that is very important, particularly when we are talking about key populations, those who are initiating PrEP for the first time, we need to look at their risk, and we need to use their risk to determine whether they need to come back for testing after 1 month, whether that testing is actually very, very essential, or whether it's something that you could skip. We also need to look at other options whereby clients can have testing done in other facilities, particularly facilities that are closer to them, but making sure that we have these arrangements in place so when the test is done, the PrEP provider will also have access to the results. Other things that could be done include even having in settings where you allow community-based workers to conduct testing within the house or within the whatever is convenient for the individual are also some of the things we're looking at within our programs. So generally speaking, the recommendation is yes, 1 month of testing after initiation, but it also depends on the client and depends on the stock level within the countries. So there's flexibility depending on what we think will work best for our clients. Thank you very much.
Hi, this is Gaston. The PEPFAR guidance is pretty much aligns with what Dr. Shona said, where this should be assessed and decided by the client and the provider together based on the client's needs. Even though we recognize that looking at PEPFAR data, you have a lot of clients that express interest in taking PrEP, but after 1 month, there is a sharp drop. So this is a problem, but given the current circumstances, I think it makes sense to decide, with the client and the providers, what is the best course for the client.
Thank you, Gaston. There have also been, oh, go ahead.
Oh, can you hear me? Great. This is Robin Eckel from USAID. Sorry, Christine, I just wanted to quickly jump in and say, I think all of the suggestions so far have been really useful and something that we've been talking about internally too, both at USAID and then in our interagency community of practice is something that Chris was mentioning, which is how can we think a bit differently about that initial testing and sort of monitoring phase of PrEP use? Can we get it out of the clinic somehow? Of course, maintaining the safety of our providers. So I think just as the months continue, we're going to have to think creatively about how to get PrEP out of the clinic while maintaining the safety of our clinicians and community health workers.
Thank you, Robin.
Hi, this is Vusile from South Africa. So the guidance that we received was for existing clients, telephonic consultations are obviously allowed where appropriate. This is just to ensure that people don't travel unnecessarily to the clinic. And for PrEP clients due for a 3-monthly HIV test, the guidance is that we ask several questions to establish this. One of which is, has the client been taking PrEP daily? How often have they missed doses? Is the client able to use a condom each and every time they have sex? Is the client experiencing any signs of acute infection? So you go through that list of questions, and based on above responses, if there's a concern that the client may have seroconverted, you arrange for the client to either come in or go to the nearest clinic to have an HIV test at a point closest to them. And for first-time initiations, we give them 1 dose. Thank you.
Thank you, Lucile. I'm wondering if we should address the issue of event-driven PrEP since that was raised. Shona, can I turn that over to you?
Yes, thanks, Christine. So I'm not quite sure exactly what the question was aiming at, but I think from our perspective, the use of either daily PrEP or event-driven PrEP for men who have sex with men, which is a 4-dose regimen of the 211, would continue and would not be affected either one way or the other. If there was something more specific that the person wanted to ask, I'd be happy to consider that as well. But at the moment, we don't see any difference there.
Thank you. And I think we can address in our resource sheet what the guidance is on event-driven PrEP. So we can put that in there. There are also several questions around using HIV self-testing as a replacement for regular HIV testing. I'm wondering if the panel would like to respond to that. Shona, this might be to you again.
All right, I'll take this one too. So from the WHO perspective, based on the current available evidence, we do not currently recommend HIV self-testing for people taking PrEP. The reason is for many reasons. So at the moment, this is not a preferred option. A particular challenge is with people who test negative but had early or acute infection, and then those were picked up at the next testing visit. On the plus side, however, in our review of the evidence, there was very little drug resistance seen. So in principle, if the tests being considered for self-testing are the same as the tests that would be used for professional use currently under ministry and national health guidelines, it could be considered. Certainly, these would not be oral tests, which have much lower sensitivity and specificity that would be acceptable for people taking PrEP. However, a really critical caveat is that anybody who tests positive would need to be confirmed with a full national testing algorithm because of the risk of false positive results. So we need very clear messaging. Like I said, we understand that these times are extraordinary, and people and staff, health facilities and programs are adjusting as best they can. And, we understand that one has to adapt to the current situation. So, we can understand that consideration, but, just to say that we do not have current evidence that this is a good approach for people who are taking PrEP.
Thank you, Shona. In the interest of time, I want to move on to, there's a lot of discussion about GBV and concerns for increased intimate partner violence during this time of lockdown. One of the things to consider is how to use PEP, so post-exposure prophylaxis. I wonder, Kelly, if you just want to comment on that and how that's an important consideration.
Thanks, Christine. I think this is something that we see in PrEP programs generally, is that sometimes our clients who are eligible for PrEP present to initiate PrEP when they have had a very recent exposure. This can be, in the case of serodiscordant couples or key populations. And so just, a reminder of how important it is at that first visit or at the restart visit to assess for potential signs of acute infection or potential risk, and to make sure that we're also considering whether clients might be eligible for post-exposure prophylaxis rather than initiating PrEP. I know in many countries are using a 3-drug regimen for post-exposure prophylaxis now. So I think particularly in the context of so much disruption to PrEP services in some settings, as we've seen today, it's going to be important for us to welcome back our clients and help them restart however they need to enter back into PrEP services, if that's using post-exposure prophylaxis and then transitioning to PrEP or restarting PrEP. I hope that answers the question.
Yeah, and I just want to, so we are at the top of the hour. I want to note that there are many questions here. There are questions around family planning integration. There are questions around to what extent can we do home visits, what PPE should be used with home visits. And so we are going to put together a resource sheet and address these questions. It will go out in a e-blast probably early next week or middle of next week. And all of these webinars and the resource sheets are available on the PrEPWatch Virtual Learning Network site. You can go back and find all the previous recordings, PowerPoints, and resource sheets, and we will do the same for this. Next slide. I do want to thank everyone for our presenters and our panelists for being here today. Obviously, there's much to talk about and not enough time to do it all in this 1 hour session, but we will continue to build on this work and share, and as we will also share some of the experiences that were put forth in the chat from the different countries so that we can all learn from each other. Please take the poll if you have a moment before you go, and I wish you all a good evening and good day. Thank you so much.